Hello and welcome to Kawia Health's Community Engagement webinar. Today is Thursday, July 8th. My name is Deborah Volleson and I'm the Director of Community Engagement here at Kawia Health. And normally I am joined by Gary Herbst, our CEO, and we spend the hour talking about COVID and all things related to COVID. But today I have a very special guest joining me today, and we are going to focus our meeting on the future and the strategic plan that has recently been approved at Kawia Health. So Mark Mertz, our Vice President and Chief Strategy Officer, is with me today. And Mark oversees facilities, consulting, the foundation, marketing, physician recruitment, media relations, and community engagement. He's been with us at Kawia Health since 2018 and has been instrumental in the changes and growth that have happened in the last couple of years, most notably when we purchased Tulare Clinic and the old IRS building became our new Tulare Center, and the rebranding. So welcome, Mark. It's really good to have you on today.
It's 3 years today.
3 years today. Wow, wow. So give us a 60-second elevator speech about Mark Mertz.
Well, it's hard to follow up Deborah's introduction, but as I just said, I've been here for 3 years today, so it's been a great start, I guess, to my time here at Kawia Health. Immediately prior to coming here, I was a consultant. I most recently worked with GE Healthcare, and I was responsible for their national consulting practice related to hospital-physician relationships. So I spent most of my time working with hospitals and health systems across the country to help them figure out how do they work with physicians and doing a lot of strategic planning. So my wife and I were living in LA. We had a weekend house in Three Rivers and I decided flying around the country and sometimes even to the Middle East was no fun anymore and wanted to settle down somewhere. And so we moved to Three Rivers, left LA, and the rest is history.
Left the big city to go to Three Rivers where
20 million people to
wrestled
2,000.
bears and snakes and okay, well,
Yep.
Welcome. And we usually start these meetings, Gary normally goes into a long narrative on COVID numbers up and down the state, but we're going to do you a favor and we're only going to ask you a couple of COVID questions.
Okay.
So how many COVID positive patients do we have in the hospital today?
So I'm happy to say we only have 7 patients in the hospital today, 2 of which are in ICU, but 5 are just in med-surg.
Okay, so we've watched those numbers, I believe, get all the way down to 4.
It went as low as 4.
Okay, then it jumped
Bounced back
back
up to 10, 12.
Okay.
Now it's back down a little bit.
So we're getting the question, are we seeing the Delta variant here?
Yeah, and so nationally, I think 50% of cases these days are Delta variant. We're not testing every single patient to determine if it's Delta or not, but we have to assume, given the fact that 50% of the country's cases are Delta, we have to assume that we have Delta here. I think one reassuring fact is that the vaccines that are out do seem to be very effective against the Delta variant and other variants.
Okay, so we've also talked the last few weeks about how full the hospital is, and we can't really pinpoint a trend, but how are we doing today?
Yeah, so I checked the reports, so we get a report every single morning. This morning, our medical surgical beds were 98% full. So we had 4 med-surg beds open this morning, and then for critical care and intermediate care, we were 75 to 80% full. So we had some capacity there, but medical surg has been running very full, and it is a mix, to your point. It's not just one thing we can point to say what's going on. There's a lot of various stuff out there. I think a lot of people probably spent the last 15 months not behaving themselves and staying home and eating too much and drinking too much and probably not doing the things they should be doing, and so that probably has contributed to people getting sicker than maybe the otherwise would have.
Right, okay. So besides that, is there anything else you want to add about COVID?
No, nobody wants to talk about COVID anymore.
We're kind of, we've opened up our visitors. We now are allowing our employees who are not in patient care areas to no longer mask as long as they have the vaccination sticker. Right. So we feel almost normal.
Yeah, it's getting back there, and I think the visitor policy relaxing has probably been the biggest benefit and the most positive thing we've seen, because we've talked about before, we hated the fact that we had to limit and reduce visitors. I mean, the impact it has on patients and their family members was unfortunate but necessary at the time. So we're
Yeah.
thrilled to see that back.
Okay, all right. So let's move along to our to the things we want to talk about today. So the strategic plan, I mentioned that it was just approved by the board
Last Monday night.
So that plan covers organizational efficiency and effectiveness, outstanding health outcomes, patient and community experience, empower through education, ideal work environment, and strategic growth and innovation. So I'm sure you've done strategic plans throughout your career for many organizations. You mentioned your healthcare experience, but can you share with us what goes into creating a strategic plan for such a large healthcare organization, and what differentiates Kawia Health from others you've worked with in the past?
Sure. So as I mentioned, I did a lot of strategic planning for clients of mine, and so typically I'd be hired to come in and facilitate, provide some kind of expert opinions, and really run the process of doing the plan. But at the end of the day, the client is the client, and they got to determine who was involved and how long they would spend. So I guess in some cases I'd be frustrated that the process wasn't as effective as I thought it could have been. And so when I came to Kawia, working with Gary and the executive team, I feel like we designed a process that's more comprehensive, more inclusive, and more detailed as far as our strategic plan. So, starting back in 2018, I think was the first news cycle that I was involved in, but we involved staff, physicians, the board members, community members even. We invited them to come in and talk about our strategic plan. So that's one thing I think that's different from most healthcare organizations is just the breadth of people that we involve, which we felt was vital. Because a nurse working on the unit has a different perspective than I might have, or Gary might have, or a board member might have. The other thing that was, I think, different is oftentimes a strategic plan would occur over a weekend. You'd go to a retreat, you'd spend 8 hours in a room, come up with a plan, put it together, and that was the end of it. Where we really spent from November until really it was just approved last Monday night working on our strategic plan. So it started with a retreat. We then identified the major areas we wanted to work on, and then we brought together work groups that again included physicians, for the medical staff, employees, leaders, and for the first time, a board member. So every work group for the 6 initiatives you mentioned, we had a board member that attended all of the meetings, were very active participants in that process. So I think our plan, the resulting plan that we have, I think is better for having involved all those different people. We took several months to put it together. And then finally, I think if you look at the plan, and we post it on the website, I believe. I know it's internal for employees, but if you look at our plan, it's very specific in its actions that we're going to take. And then for each action, we have very measurable metrics that we can, on a monthly basis, see how are we performing against those. Are we being successful, or are we missing the target? And we track that monthly. We report to the board on a quarterly basis, so there's a lot of accountability, especially this year. Coming out of COVID, we need to be successful. We need to execute on this plan. So having that oversight from the board and their involvement throughout, they're very familiar with it, very engaged with it. And so I feel like this plan is just more, I guess, rooted in reality and very closely aligned with our budget. The other thing I should mention is our strategic planning process works together in concert with our financial budgeting process. So finance and strategic planning works hand in hand to make sure anything we're talking about doing in the strategic plan is captured in the budget, both from an expense standpoint and a revenue standpoint, so that we have the resources to implement what we say we're going to do, and then any of the growth that we're projecting is in the budget. So it's really an integrated financial and strategic plan.
Right. So you had work groups that actually created the strategic plan. So now that it's approved, you're going to have work groups to implement the strategic plan. A lot of times those things, you never really hear about them once they get approved.
Yeah. So there are leaders who are responsible for tracking the performance in each of those initiatives. We have an internal consulting team that facilitate a lot of this work, and they're going to help monitor how we're doing and report on it. But a lot of it does fall back to the operational owners. If we're talking about a strategy to increase volumes in our rural health clinics, for example, and that's going to be Ryan Gates and his team are really responsible for executing on that. We might have a team that's helping them track it, but it goes back to the operational owners to fully implement and execute.
Right. Okay. That's great. So one area that you are ultimately responsible for is the strategic growth and innovation. And so one category under that is properties and facilities. And so can you give us some updates on the Kawia Health properties and facilities that either have expanded and you're waiting on things, or that are going to be expanding?
Yeah, so we've got more than 50 buildings under Kawia Health, and so there's always work to be done, maintaining, upgrading, expanding, replacing our facilities. Frankly, some of our facilities are a little bit old and need to be updated, and we'll talk about some of those in a minute. But at the same time, our community is growing. More and more people are moving to the area. They're moving in different areas, and so we constantly need to think about where we have locations, especially clinics, to make sure that they're convenient to people, that they have access to high quality care, because not everybody has the ability to travel to Visalia, for example, to come downtown. So we want to make sure that everything's convenient for them. But then it comes down to cost. And we unfortunately don't have an unlimited budget or funds to invest in new facilities. It would be more fun if we did have that, but we don't. So we need to be good stewards of our resources, because at the end of the day, we are a public institution, it's public funds. So it's kind of a constant balance, and we have to prioritize what we do today versus what we have to put off, whether it be maintenance or replacement for coming years.
Yeah. So a lot of our projects are hurry, 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 get them done, then sit and wait. And so, like, for example, the ED refurbishment, we were, and a lot of the people that are joining us online came for tours, and we have been talking about this really since March, that it's going to open, and now we're sitting and we're waiting.
Yeah, so most construction work was completed in March. We were really ready to open in April. So we did file with the state, so it's under the jurisdiction of the California Department of Public Health. So we let them know we're ready. They came into a visit. They said things look okay, and then we filed our final paperwork to open the new Zone 5, which is a clinical area, as well as the new waiting room or reception lobby area. And so far we've not received that permission. So they initially turned us down to open. Their concerns were primarily related to physician staffing and resident physician staffing. So we worked up a new staffing plan, submitted that back to the state. It's actually a department that's out of Bakersfield. It's not the Sacramento office, but we're handled out of Bakersfield. So we resubmitted the plan about how we're going to handle patients, although it's not like we're going to see a 50% increase in patients tomorrow just because of a new ED open.
Right.
It's really going to be the same number of patients just in a new facility. So, but we submitted our new plan. That was turned down. We refiled, and now we're waiting to hear. And so actually I was meeting with Carrie Nowesky just about an hour ago, and she put personal phone calls into the Bakersfield office to find the status, and we're still really working with them to get approved. So personally, it's frustrating. You mentioned being responsible for facilities. We pushed hard to get it done as quickly as we could. And then last Friday, I was walking through the ED with some of the ED management staff talking about space planning, and it was frankly frustrating to be looking at a beautiful new facility and just realizing we can't use it.
Right.
And we have patients in the Mineral King lobby, which it was never designed for that. It's not a great environment. So we're desperate to open it. We're doing everything we can. We've had local politicians offer some assistance to place some phone calls to the state, so we might have to call in some favors to do that.
Okay. All right, so Sequoia Gateway. We are in Escrow, and what can you tell me about this property?
So Sequoia Gateway, for those who don't know, this is the intersection essentially of 99 and Caldwell Avenue. You've probably seen some dirt being pushed around there. You may have seen some of the plans that exist out there, but it's very
actually
ambitious.
Looking nice.
It is. The roads are in. There's some utilities in. I think some construction's beginning to start. Some signage is in there. So if you haven't seen it, there's some very ambitious plans out there for restaurants and gas stations. Originally, they planned a large retail presence. We'll have to see what happens with retail, but office space, and then most interestingly, Valley Children's Hospital will be opening a clinic there. So I know there's been some rumors that it's a hospital, but they're really just opening a specialty clinic out there. So we are in Escrow on 7 acres, immediately along 99, which is just a great, very visible location for us.
So when is Escrow going to close?
So part of the land that we bought, there's an irrigation ditch that essentially runs almost through the middle of, there's 3 lots that we bought, and we're merging them, but there's an irrigation ditch that runs right in the middle. So we needed them to move that to the border, because we can put a parking lot or a driveway over a ditch, but we can't put buildings on top of it. So to have the greatest flexibility, we asked that they relocate that ditch, and they're in the process of doing that. that's going to take months, I have to imagine, for them to do that. So we'll sit in escrow, which is fine for us right now, until that's completed, and then ultimately close.
And then after we close escrow, what are you thinking about putting out there?
Yeah, we don't have definitive plans yet. What we do know is that we're very congested downtown. It's we have a relatively small footprint down here. We filled it up with a lot of stuff. So what we're thinking, and we still have more work to do in this area, is that it would be outpatient services, ambulatory services. So we might put out there some physician clinics. We might move outpatient surgery out there because today, inpatient surgery and outpatient surgery is all done, for the most part, in our downtown campus, in the same ORs. If you're coming in for a same-day surgery, you need to drive downtown, find somewhere to park, and deal with all that. So that's not the best patient experience. It's pretty congested, as I mentioned. And then, frankly, we're getting short on OR space. So it makes, at least some initial, very good sense to move those outpatient cases, which is about 48% of our surgeries downtown. Can we move those cases out there, build an ambulatory surgery center with physician partners, and give patients a great experience? You know, parking as far as you can see, you know, modern facilities, very convenient in and out access, and then at the same time create capacity down here so surgeries that have to occur on the inpatient basis can be done here, give greater access to surgeons, to ORs. That seems to make a lot of sense for us. Then you might, around those services, you might add imaging services or other outpatient ambulatory surgery services. So we never envision putting any inpatient work out there. The inpatient hospital will remain downtown, but we might decompress downtown, help parking, create a better experience if we put people out there. So we're going to have to think through it. So once we close, we'll spend time working with our board, our leadership team. We have various physician partners we would want to work with on this. So the physicians in Visalia Medical Clinic, the investor partners that we have in the Sequoia Surgery Center, we would want to keep them engaged and get their support for anything that we do out there.
So that location, I was going to ask you why you chose that location, but you've kind of just said several of the reasons, but that just opens up Bakersfield, Fresno, and you mentioned there could be dining, maybe a hotel out there, but
Yeah, multiple
that
hotels.
would be a great place for families to be able to come. Their family member have surgery, them have services right outside. Yeah.
Yeah, as you think about our broader service area, it's really pretty central. You know, historically, we've been a very Visalia-oriented hospital. I would suggest that we're more of a county or two-county health system now. So that is a pretty central location. I love the visibility. They're going to build a 90-foot sign for the development along 99 that we're going to be top branded with Valley Children's up there. So it just gives fantastic visibility to a broader audience. And as you said, I think we'll be able to keep more patients local. One thing that we strive to do whenever we're thinking about service line planning or facilities is how do we keep care local, because we believe that keeping people closer to home for care is better for them, it's better for their families, if they don't have to travel to Los Angeles or the Bay Area to go get something done. And a lot of people do leave, frankly, right now. We know that. We're able to track when people leave the community. So I think this will be a way to keep more of those people local, give them a modern, world-class facility.
Right. So when it first hit the news a couple of years ago that Valley Children's was building out in that area, you know, we received a lot of comments like, are you worried that they're building a hospital here? And it is just a clinic. But a lot of people don't realize that we have a partnership and a relationship with Valley Children's now.
We do. Long-standing, fantastic relationship with Valley Children's. On the inpatient side, so in the hospital, their physician staff our pediatric unit. They staff our NICU unit, and they respond to the ED. So we have Valley Children's physicians in the hospital every single day providing care to kids, which is fantastic.
Right.
First of all, it's fantastic care. And then second, if they do need to be transferred, they can really facilitate that transfer right up to Madera. Great. But then we also have, there's a clinic on Acres that they've had for years that we support, work closely with our physicians. We do provide some financial support to it. So, you know, we've been in conversations with Valley Children's about what they plan to do at the Sequoia Gateway project and what we plan to do, and I believe that there's synergies there. In fact, I had conversations just very recently about that, and so I can't tell you today exactly what it will look like, but I think that the synergies between having Valley Children's and Kawia Health out there, I think it's going to be great for the community.
Yeah, absolutely. So I'll ask the burning question that I think everybody wants to know. How did you come up with the money to purchase the land at Sequoia Gateway?
So we were fortunate in that regard. I think the final purchase price was $2.8 million. But we had proceeds from selling land in Southeast Visalia. So we had originally purchased over 100 acres in Southeast Visalia on the corner of Caldwell and Lovers Lane. We sold a majority of that land, about 88 acres, I believe, to Visalia Unified. And so we used just a portion of those proceeds to purchase the land at the Sequoia Gateway project. So, for me and I think for the board, it was a great way to maintain two large land banks. One's over 20 acres, now one's 7 acres. That just gives us a lot of flexibility to respond to how the market grows.
Right. So we kept 20 acres at Caldwell and Lovers Lane just for future. You know, maybe doing a campus like we did out on the West Campus where Lifestyles is. That's about the size,
It is,
right?
yeah, that campus on acres, which has our mental health hospital, rehab hospital, Lifestyles, Sequoia Regional Cancer Center, the medical office building, that whole thing is about 20 acres. So having that land available in Southeast as we see how the community develops is awesome to have.
Right. And we sold it to the Unified School District. So if growth ever starts moving out in that area, we're set.
Yeah, and it might that growth might start with a school.
Right, right. Okay, so industrial park. There was an article that was just in the paper about Kawia looking at the industrial park. Is there any truth in that?
There is. So I mentioned before, we're always looking at where are there needs in our community? Where are there needs for various services? And in this case, the industrial park is doing awesome. It's doing fantastic. I mean, look at the announcements from Amazon with 2,000 employees moving out there. UPS, I think 1,600 employees. And more businesses to come. It's a high growth area. But if you look at the Plaza corridor, I don't think there are any clinics out there. So we thought it made a lot of sense to go out there, but we're doing our diligence now. So we've identified potential land, but before we make any decisions, we're meeting now with business leaders. I mean, you and I are involved in meeting with community leaders, business leaders out there to talk about, is there truly a community need that's not being met today? Because we don't want to oversaturate, we don't want to duplicate services, but if there's an unmet community need, we're going to look to fill that. So it just seems like there's something there. We're working that out now. I envision it probably being a small primary care location with probably walk-in services, maybe some workers' comp. I mean, thinking about the type of workers going to be out there working shifts, potentially with some small injuries, it might be nice to have a occupational medicine work comp clinic out there.
Right. And you mentioned doing due diligence out there. You know, it's really easy for us to think we know what people want and need, but it's very interesting when you're talking to the business leaders and they say, here's what we're looking for, here's what our employees, they make a very clear path for you in moving forward.
They do. And ultimately we're there to serve their employees. And so I think their opinions and their input is vital to us making the right decisions.
Absolutely. Okay, so let's move on to inpatient and outpatient services. So how do you determine a needed service, and how do you decide which service is more important than another?
Yeah, great question. I mentioned that we're always looking at the market to understand what's currently unmet. And the ways that we do that, first of all, is we actually are able to acquire claims data. So if whatever insurance you have, whether it's Medicare, Medi-Cal, or a commercial insurance plan, when they pay claims, there's a record of that. They pay for that service to the provider. And then there's companies that aggregate that data and they make it available to providers like Kawia Health. And so we actually get this data and we can see when people leave our community. I mentioned before that a lot of people leave our community for various things. So we can see down to the procedure level what those are. So we know, for example, bariatric surgery. There's 150 bariatric surgeries performed on people that live in Visalia, but they had to leave the market to get that. So that's one way we know what's not being met locally. And then second is we talk to primary care physicians. Brittany Taylor and the team in physician relations and recruitment talk to doctors every single day. So as we talk to our primary care doctors, we can ask them, what do you have to refer out of the market? Or what is there not enough access here locally for your patients that you need to find elsewhere, or patients can't get care? So talking to them, we can identify potentials. But then it really comes down to prioritization. And a lot of that occurs during the strategic planning process that we just finished because we can't afford to do everything. But it's balancing the community need with our resources that we have, whether resources be our time because we can't do everything, or our money because we don't have enough to do everything. We have to make decisions about what's best for the community, what's best for us. we don't have to make money on everything that we do. In fact, we don't make money on everything that we do. There are services today that we provide that don't make money for us, but it's vital for the community. It's necessary to be provided. So we do our best to break even on everything that we do, but in some cases we have to make investments. But at the end of the day, we got to stay in business.
Right.
So the financial considerations are very real. So it's a prioritization, and we go through that strategic plan with the board, with the executive team, and with those committees to determine, okay, we've got 5 new things we want to do this year. We're going to do 1, and we'll do 2 next year, and we'll do 3 the following year, that kind of thing.
Right. So what are some new services that are at the top of your priority list?
The very top would be behavioral health. I think if you look nationally and you look locally, there's just a huge need. There has been a huge need for years for behavioral health, mental health. We don't have enough providers providing those services. People are suffering every day from it. We see it in the hospital. We see it in the ED. I think COVID has only exacerbated that, especially when you think about children. So we're working very hard to improve that. We're very fortunate to have our psychiatry residency program. So we're training new psychiatrists in the community. They're seeing patients during that training. We have attendings who are seeing patients, so they're providing fantastic care under Dr. Baga's leadership. We also recently this year received a state grant for behavioral health integration, which is extremely exciting. So it was about $3.6 million that we received that does exactly what it's titled, which is integrates behavioral health with other services. So in this case, all of our primary care clinics, we're looking to integrate psychiatry, therapy, and counseling in those clinics, which is just awesome. You think about families who have established care in the Tulare Clinic, for example, not only can go there for their primary care, but now if they have mental health, behavioral issues, there'll be someone there that they can see. And so state funds have helped with some facility work that we needed to do, but also recruiting psychiatrists. In fact, we just hired 2 of our 4 graduating psychiatry residents this last month, which is awesome that they can stay in the community and meet this need. So BHI is a fantastic program. And just this last Monday, when the board approved the strategic plan, they also heard a proposal to add a child and adolescent psychiatry fellowship, which would be just fantastic for this community. So today, the way it works is you go to medical school, then you go to a residency. In this case, you would go to a psychiatry residency like the one we have at Kawia Health. But then many of those folks want to go on and get additional training, so that's called a fellowship. So they go for an additional 2 years of training to be able to treat children and adolescents. Today, they have to leave the community to go get that training. So this fellowship program would allow us to have 6 fellows, 3 in the first year and 3 in the second year, who would practice in the community, be able to see kids and teenagers locally. And then hopefully, if they've been here for the residency and they've been here for the fellowship, they now like the community, they like Kawia Health, and they want to stay, and we can just continue to add providers to this community to provide just a vital service. And so we're getting a lot of support from the county. We're looking at additional grants potentially from the county. We're working with Valley Children's just to bring vital services to the community.
Okay, so right now, is it just our Exeter clinic where they can get mental health services for children?
No, also Lindsay. So
Lindsay,
Dr. Jakes,
okay.
who is leading the effort to create our child and adolescent fellowship program, sees children in Lindsay. The county also does have clinics, primarily for the Medi-Cal population.
So if you're a privately insured family with a child that needs to see a psychiatrist, you're out of luck? Or do you have
harder. It's harder. The wait times, unfortunately, locally are very long. We're working to improve that. We're also looking at it, and we're doing a lot of mental health work. We're also looking at adding a commercial clinic that would be available to those patients who have commercial insurance and Medicare insurance, so both adults and children could get access here. But again, we're working very closely with the county just to increase access to all of these services locally because it is vital, both on the outpatient side and then on the inpatient residential side, because we obviously have the adult behavioral health hospital locally. There's no inpatient resources for children.
Right.
And sometimes we have to search far and wide to find somewhere for them to
So
go.
where would they go?
It could be beyond to find somewhere for a child to go, which I can't imagine the impact that has on the kid being away from home, the family being away from home. So we've got to fix it. And we're fortunate to have support from the county, to have fantastic leadership with Dr. Baga and Dr. Jakes and others in a residency program. So we're going to fix it. We're going to improve it. But
So it all comes down to physician availability?
it's the funds to invest in the facilities. which we
Okay.
just don't have a lot of capital
Okay.
to invest in facilities, and we have a lot of capital needs. So it's looking to the state mostly for the grant funds to build the facilities, and then you're right, then it comes down to getting the physicians. So we think having the residency and the fellowship will train the people that we have, give them exposure to the services in the community that we have, and encourage people to stay locally. So
Okay.
I think we've got awesome opportunities to really make a huge impact on behavioral and mental health in this community, which coming out of COVID again is just going to be
Yeah.
vital.
Well, and several people on this call have been either a part of our advisory committees or on our ambassador groups, and we've been talking about mental health since they started back in 2017. So it's a big problem, and we know you're working on it, but it's something that will be very, very celebrated when we can offer that to our community. So what other services besides behavioral health?
Yeah, so we talked about a new fellowship potentially. We have 6 residency programs. We're looking to potentially add a 7th. So internal medicine, we're contemplating, and the board heard an initial proposal last week. They haven't been asked to take action yet. But this would be a rural internal medicine residency program. The idea would be, like our other programs, is to bring people here to learn, to train, to create new physicians who grow to love the community, want to stay. But with internal medicine, they often go on to those fellowships I described in things like gastroenterology and other specialties that we desperately need. So we think that could be a great pipeline to create more physicians who come back and provide services. Speaking of that, urology, we have a huge need in urology. We've had some physicians retire, so we desperately need more urologists. GI physicians, we desperately need more GI physicians for gastroenterology, so we're working very hard in those areas. I mentioned bariatric surgery earlier. That's one that we're looking at now. We do have 150 people who have to leave the community for those surgeries. And not just the surgeries, but there's 6 or 9 months of pre-op work and post-op work, and so it really isn't good for patients to have to leave the community for that. We're very excited to be adding colorectal surgery. Dr. Kyle Oda graduated our residency program in surgery last year, went off and did a 1-year fellowship in colorectal surgery. He's coming back to the community. Again, testimony to our residency program.
So did he have family here, or what was the draw for him to come back?
He didn't have family here. He just enjoyed the area, I think, and he saw the opportunity. There's no colorectal surgeons in this part of the valley, so I think he saw that opportunity. I think he liked the community, he liked the people, and so he's coming back. So he'll be here in August rather. That'll be fantastic. And just in general, we're looking to add physicians. We're looking to add 20 new physicians in the next 12 months. So hopefully lots of new access and services in the community.
Right, so let's talk about some of the barriers to being able to add these services. Besides physician, what else? Besides
physicians
getting
is huge.
physicians.
That's huge.
Yeah, okay, yeah, I kind of
And I mentioned
downplayed
GI
that.
and urology. They're in demand everywhere. And the whole country is looking for
So
these.
why is that? Why is there just a shortage of?
People just don't go into them for various reasons. They don't go into that training. They don't pursue it. And
Is that the same thing with psychiatry? Are less and less people going into that field?
I don't know if psychiatry is impacted as those others. But also, frankly, the earning potential for urology and GI has gone up.
Okay.
And so it's highly competitive. So we're competing against Newport Beach and San Francisco and New York and everywhere else. And so it's hard to find those doctors. And we have to support them to come here. And so we do look for people who have ties to the community, whether they're from here or they have family here or they trained here. That's the best way we can get physicians to come. Other barriers are money. I mentioned financial support for doctors. When we recruit doctors, we typically pay their relocation costs. We pay sign-on bonuses. We pay to forgive some of their loans. And then we give them income guarantees. So that can be millions of dollars a year that we're paying to support physicians because it's hard to create a practice in the Central
Which
Valley.
is very confusing because we don't employ physicians, but we give them money.
Correct.
So that's kind of confusing.
It is. And so California is one of probably 5 states you cannot directly employ physicians. A hospital cannot employ physicians. Most hospitals, in fact, most that I worked with, that was a fundamental strategy. We're going to employ more doctors. It's easy.
Right.
You offer them a job, you hire them, you give them a W-2. It's fairly simple. For us, it's harder because we can't employ them. So we typically, if we can demonstrate a community need in a certain specialty, So we can say we don't have enough colorectal surgeons. We can provide those financial support measures that I talked about before to a colorectal surgeon that does not live in the community but agrees to move to the community. We can give them, within certain parameters, financial support to come.
And then we help them build their business, and our
We help
teams
them build
work with
their business because it's not easy to build a practice, and it's harder to do it in the Central Valley. We're 60% Medi-Cal, which frankly a doctor cannot make money on Medi-Cal. They lose money by seeing a patient in their office or doing a surgery. But that's our population. We exist to serve our community, whatever insurance they have or do not have. So we're committed to doing that. So we make the investment to help support these practices so they can see all patients in the community.
Right. So you say 20 new physicians in the next 12 months. So is that the timeline? You have 12. How many have we brought in the last 12 months?
So the last year's strategic plan that just ended, our goal was to recruit 30 new physicians into the community. And Brittany Taylor landed the 30th physician with days to spare.
Oh my goodness.
So that was awesome. So
yeah.
when we say 30 new physicians, that doesn't mean they work at Kawia Health. It
Right.
just means they're in the community.
Right.
Frankly, we're more interested in having people here than we are at having them work, for us or at one of our facilities.
So we partner with other facilities to help onboard these physicians, or is it?
We do. We help them recruit. Some private practices, we might just help place ads and interview candidates and help bring them in. It might be as simple as that. Or we might just help place our residents, whether it be with another hospital locally or an FQHC. We might just help make that happen. But we're just so fundamentally understaffed from physicians in the community. We're frankly happy to have them here in any way, shape, or form. So
Right.
We hit our 30 last year, which was awesome. The goal this year is 20.
Okay.
And it's a combination of primary care and specialty physicians. So I've got every confidence that we can bring in
Right.
20 more. But we won't be done. We've got more to hire to meet unmet needs, and then we have an aging population of physicians.
Right.
Probably a third of our physicians are kind of nearing that retirement age, so we got to replace all of them too.
And so if somebody comes in needing one of these services that is in short supply or that we basically don't have, we have to send them out to other facilities?
In some cases, we do. If we don't have coverage at the hospital, we might have to transfer them or refer them to another hospital. But in many cases, patients are just seeking care elsewhere. If they're looking for GI services, they might make some phone calls locally. It's a 6-month wait, so they call Fresno and then get in a month and
Right.
they drive to Fresno.
Okay, how are we doing with retaining our physicians? Once we recruit, they come. How are we doing with the retention?
So we just really started looking at that this year. We started tracking turnover rate of physicians, how many physicians are retiring or leaving the community. So it's kind of too early to tell on how we're performing on that. But we do spend a lot of time on it. I think one of the community engagement committees actually came up with some ideas for work that we can do, as you said, not just to get people to come, but to give them a nice soft landing into the community. So we have a combination of our employees and then community members who have volunteered their time to help meet with new physicians and their family members, to get them connected to churches, to real estate agents, to accountants, to whatever they might need, to service clubs, just to make them feel part of the community. That helps them want to stay. It helps them build a practice, frankly, by getting out and meeting people. So I think we're doing some great work with our community partners, and time will tell.
Okay, and when we recruit physicians, the ones that just come to the top of your mind, where are we recruiting them from?
Well, we're most successful if they're trained here or from here or from some of the other organizations that we work with. But frankly, we recruit from everywhere. Our physician recruitment team is placing ads around the country. We go to events around the country, essentially job fairs for physicians to talk to them. So they're coming from all over, but we're most successful if they have some sort of a tie to California or more specifically the Central Valley.
Okay. All right, so the Hospital of the Future Advisory Committee, this is one of our committees that started back in 2017, and they have been working on a master facility plan, really pretty much since 2017. So I don't know if you want to go into a little history of where, I know we have an architectural firm, we've been working with RBB, but where are we at in that process and what are the next steps?
Yeah, so this is all really around the Mineral King Tower. It was finished construction in 1969, so it's older. It was probably cutting edge at the time, but isn't anymore. The rooms are too small. They're designed before we get computers or some of the equipment that we have. It's hard for family members and patient friends to come in and be in the room with them. So that's the impetus for this. We need to replace that because it's older. It's hard to work there. It's hard to recruit people to come work here or physicians to come practice here in that building. At the same time, the state says we can't use it past 2030. So SB 1953 is the state regulations that says buildings of certain age and design, which ours falls into, cannot be used past 2030 for seismic concerns. They're afraid that there's an earthquake and it'll fall down. So SB 1953 is very real. It's still in effect.
And they're not standing down from that?
We thought maybe last year we'd get some relief. There was a bill proposed that would extend that 2030 deadline by 7 years and change some of the requirements. But it got modified and watered down so much in different committees that eventually the sponsors of the bill pulled it back and said, forget it, we'll try again next year. So no, right now we can't use it for medical care, for patient care past 2030. We need to modernize, we need to replace it. But that 2030 deadline is what really is difficult for us because frankly that's not that far away. But if you look across the state, we're not alone. There was a study last year that looked at all the hospitals in California. So district hospitals, there's 38 district hospitals in California. The study I read, 97% are in the same boat as we are. 97% are not compliant with SB 1953 and can't use their hospital past 2030. So my math, that's one out of 38 is in good shape. The rest of us need to figure this out.
And the state is not offering assistance in any way financially?
No, completely unfunded mandate. And that same study looked at all hospitals that need to be replaced due to SB 1953. It's $143 billion to replace all the hospitals that need to be replaced by 2030. And no funds from the state, no additional reimbursement, no loans, nothing. And so you need to somehow fund that out of your normal operations, which
so
is a challenge.
Do we have a lobbying firm or people up at Sacramento who are fighting for us as a district hospital?
So we've got local politicians, certainly, that we work with on a regular basis, with Devin Nunes and Devin Mathis and Shannon Grove and some of the others who are very supportive, who understand the challenges that we face, especially being in this community. I mean, I go back to the fact that we serve everyone, insurance or not. We take care of them, and it's 60% Medi-Cal, so we don't have the funds that somebody in the Bay Area might have or our friends in Newport Beach might have, and so we're more challenged. So they're working with us, the California Hospital Association, the District Hospital Association. In fact, Kawia Health was featured in a study put forth by one of those advocacy groups. An interview with Gary was one of, I think, 2 case studies that talked about here's essentially a sole provider community hospital that can't afford to meet the needs in the given timeline. We fully agree. We want to be a safe facility. We want to modernize. We want to replace the Mineral King wing. We just need time and some help getting there. We can't do it on our own.
Right. And so, but regardless of earthquake safety and SB 1953, I mean, the Mineral King is old. The Mineral King wing is old. It's pie-shaped. You can't get equipment in and out. People gripe. They hate when they start out in the Sequoia wing like cardiac, rooms, and then they get moved over.
Yeah.
And we've even had some that have called it, the difference in like going to a Hilton and then going down to a Motel 6. I mean, it needs to be modernized. It's old.
It's 50 plus years old.
Yeah.
We built it before we went to the moon. It's got to be replaced.
Yeah.
And then also, there's 206 beds in the Mineral King wing. We have 435 beds downtown. So if we were to lose it, either because it got too old and it wasn't efficient or effective anymore, or because the state said we can't use it, we just can't afford to lose 206 out of 435 beds. I mean, I mentioned today we have 4 med-surg beds open today. COVID demonstrated that we need that capacity in this community. Frankly, we need more than the 206. Our current plans are to replace the 206 with 240 beds. Given the last year that we have, I worry if 240 is enough. Do we need to, because we did a study 2 years ago, and that was the projection. We needed to open the 5th floor and then add 240 new beds to replace the 206. We're going to have to redo that study to understand what is the community need going to be 30 years from now, because we're not going to build another hospital
Right.
in 10 years. This one's going to have to last us 4 years again.
I remember sitting in some of those meetings where people were talking about telehealth and online, and they were like, who knows if we will even need that many beds in the future.
Yeah.
But we're really seeing that even with telehealth services and online capabilities, we still have to have hospital beds.
We're always needing hospital beds.
Right.
But you're right. I mean, the industry is moving towards more outpatient, which is why we think what we're talking about doing out at Sequoia Gateway at 99 makes good sense. But you're always going to need inpatient beds for the sickest of the patients that you have. So the community's growing. We have more and more people moving here. We've had hospitals locally reduce the number of beds that they have, and so we've had to grow and to meet those needs. And we're looking at it. You mentioned telehealth. We're looking at the concept of a hospital at home, which is something that's really risen to prominence in the last year, where essentially you as a patient are admitted to your own home. You might come into the emergency department. We determine, yes, you need to be admitted, but we can safely admit you to your home. We can provide monitoring equipment that you're connected to, that 24/7, we can monitor it in our hospital in a command center. You can hit a nurse call button and talk to someone. Nurses and doctors come see you in your home, but you're not in a hospital bed. You're at your home. It's more comfortable. It's still safe. Adventist has done this locally and throughout the state, and so we're very actively looking at that. I think that'll have a place in what we do going forward, but we're going to need hospital beds, and we're going to need more.
Right.
So we have to replace the Miller King wing.
Right. And, you mentioned that the hospital lost money during COVID, but a lot of people lost money during COVID. And all signs, anytime we talk about master facility plan and building new buildings, all signs point to general obligation bond.
The worst kept secret.
And, we're not going to sugarcoat that or to try to act like it's not something that's on the table. So, how does an organization, how do they go about figuring out if a bond, first of all, if it's even necessary, and then, but more importantly, if a community would even support it?
Yeah, and first I get it. Going to the community after COVID, which has impacted everybody financially and otherwise, to go to them and say, here's a new tax on the property that you own to pay for this hospital. None of us want that. None of us do. But the reality is, we serve the market that we serve, and the patients that I mentioned, and the payer mix that I mentioned. But despite that, we want to have world-class care here. Regardless of what your insurance is or isn't, you deserve world-class care local, close to your home. But it's going to cost $550 to $700 million to replace the Miller King Tower and build a new hospital. And we frankly don't have that money to do that. We did lose about $30 million as a result of COVID. That's after the federal money that we received. But even without that, that's a huge amount of money to come up with. Now, we believe it's an investment in the community. I mean, this is a facility that will serve us for decades. It'll serve kids and grandkids and allow us to bring those services that we talked about to the community. It'll allow us to recruit physicians to the community to provide that care. But it's going to have to be a community investment. I mean, we're going to have to look for support from the community in the way of a general obligation bond. We're hoping and we're looking at how much debt we can take on to pay for it ourselves, and we're hoping to get to about a 50-50 balance, that Kawia Health uses cash reserves and takes our own debt to pay for half, and then we look to the community for a general obligation bond for the other half. But we have to balance that with being good stewards of public funds. We're a public hospital. We need to maintain good cash reserves for a rainy day, but still be sensitive to the community. So there are no final numbers. We don't know the final plan. You asked where we are in the process. We have been working with RBB Architects. They're out of Los Angeles. They've got a great track record of building lower cost, efficient hospitals, because it's not just how much does it cost to build the hospital, but how much does it cost to run it. So they look at, how many steps does a nurse have to take to get to different rooms, and so we feel very confident that they're a good partner to work with to design the hospital. But frankly, what exactly the hospital looks like hasn't been determined. We're going to want to work with the community to decide, what does it look like? Is it one tower? Is it two towers? When do we do it? work with our medical staff and our employees to figure out what does this space look like, how do we design rooms and nurses stations. That's all to be determined, but we kind of know the ballpark is this $500 to $700 million, and when we look in the bank account, we don't have it, and so we're going to have to figure out together, is this something we want to invest in as a community? Do we feel strongly that having a large, comprehensive hospital here that's modern and provides all the care and convenience we want is important to us? I think it is. So we're going to work with the community to try and support it.
So you've only been here since 2018, but I was one of the lucky ones who was here during Measure H, and so even the term general obligation bond just makes me a little uncomfortable on the back of my neck. And but after that, after the 2016 defeat of Measure H, Kawia Health really made an effort and said, we will never do things the way we did them in the past. And moving forward, this is what we're going to be doing differently. And so as you even look towards a general obligation bond, maybe in the next couple of years, what are some of the things that we are going to do different than we did back in 2016?
Yeah, I wasn't here for that, but I think we're still taking lessons learned from it. I think there's a lot that we have done. I mean, your role leading community engagement was created partially as a result of that, and all the various committees that we have was an outcome of that. And so I think it's just communicating with members of our community in different ways, in more ways. And it's not us telling them what we're doing. It's a real dialogue back and forth. What should we be doing? How should we do it? When can we do it? And getting their input, I think, is vital. One of the criticisms from 2016 was that, there's the Kawia Healthcare District, but we serve a much broader geography. In fact, almost 50% of our patients come from outside that district line. There's criticism of, well, how come they don't pay taxes? Shouldn't they be paying taxes? And so we did commission a study in 2019 that looked at where patients come from that we serve. We looked at what would that process look like, because there are other healthcare districts in the county that don't have hospitals anymore. There's Alta, which is Dinuba, Cutler Rossi. There's Exeter, which runs an ambulance district. Lindsay has been very supportive of us, but we frankly looked at what would it take to consolidate those. We talked to LAFCO, which is the county agency that oversees special districts, and frankly, Kawia Health or Kawia Delta Healthcare District nor LAFCO, neither one of us are going to force consolidation. It would have to be that another district would want to work with us and consolidate and come together to support this. So we've talked to some of the districts. They're kind of independently spirited. There's maybe some more conversations to be had there, and they might support us in other ways. So there's that. But I think it's just a lot more communication. I think we're starting now to talk about what options do we have for designing the facility. And it's going to be, I hope the community gets tired of us talking about it, because we're going to talk about it in town halls, in online, in service clubs, every which way we can to get their input and feedback on all major aspects of what we plan to do, whether it be designing the facilities or a bond and what that looks like. We're going to be as transparent as humanly possible, put everything on the table, because I know one of the criticisms last time was maybe it was rushed or we weren't as clear. We're going to put everything out there, have very open dialogue back and forth, and figure out what is best for this community.
And we're starting now.
We are.
In a few days.
Well, we've actually started. So we've actually begun doing focus groups. So we hired a firm to come in and facilitate, I think it was 5 2-hour focus groups with members of our community to talk about the Mineral King Wing, the need to replace it both from a modernization standpoint and a seismic standpoint, talk about that impact on the community, how we can get there, bond measures, rates. The feedback's been fantastic, very open and honest. Frankly, it was more positive than I had expected, the support that people had for the replacement and the bond, but we had 2 hours with those people, so they weren't uninformed. They got a lot more information than voters got the last time, so we have to spend 2 hours with all the various members of our community, educating them on the why and the how, and then they can make hopefully an informed decision on whether that's something they support.
Even when people have negative feedback, it's good to hear that. It's good to the why behind that. It's like, okay, so what do we need to do as an organization to change that negative feedback?
Or provide more information. Just to answer the questions and concerns that you have, because as taxpayers, you are voting to support this.
Right.
So we owe it to them. There's also employees and medical staff. So I think what you were mentioning is we're about to launch surveys, both internally with our employees and with our medical staff. Again, laying all the issues out there. Here's what we're faced with. Here's some options for how we might replace the facility, whether it be 1 tower, 2 towers, 8 years from now, 12 years from now, how it's going to be paid for, all of those things. We're going to ask their input, and then we're going to put a survey online. So our website will have background information as well as a survey that general members of the public can complete, and we'll collect all that information, focus groups, employees, medical staff, general community, and learn from it. And we'll use that to make better decisions. We'll use that to educate the board on the decisions that they have to make. And then every step of the way forward from here till whenever it is that we potentially go for a general obligation bond, we'll have a lot of dialogue.
Yeah. So the road ahead seems a little challenging, but it also is exciting. Growth and innovation are exciting. So we have a question, and we're almost out of time, but I want to why are you creating focus groups when there are already well-informed community advisory committees?
Yeah, it's a great question, and I think we'll be having similar conversations with our community advisory committees. I guess the difference I would say is most of those folks have spent almost 3 years with us now, learning a lot about us, and so they're more informed than the general population. So we wanted to get more of a cold read from the community as far as where they stand. So that's the difference, but we will be working very closely with the community advisory committees that have been vital to us.
Absolutely, absolutely. And all of this information, the surveys and everything that is going to start rolling out, our advisory committees, our ambassador groups, they will be a part of all of those as well. So, well, Mark, thank you. We have filled an hour, and you have been a fabulous guest with just tons of information, and we appreciate your transparency and just your ability to sit in here and talk to us. So
it's a wonderful set you've put together, by the way.
We're trying new things after a year and a half, right, Maria? We're like, we need to change this up a little. But our time is up, and we just want to thank all of you for joining us, and we will post this on our community Facebook page, so you can go back and watch it later, and it will also be on our Kawia Health YouTube page. But we appreciate you taking the time to just spend a few moments with us and learn about what's coming around the corner regarding Kawia Health and programs and services. Thank you, and have a great rest of your week. Bye-bye.